Dear colleagues, it's a pleasure to be here with you again on my 6-month progress report. Today I will talk about the screening and prevention of preterm birth. I'm a third-year resident doctor at the Department of Obstetrics and Gynecology of the Semmelweis University, and I'm also a PhD student in the Translational medicine. And I'm really grateful to be here with this enthusiastic group, and I would like to share my vision and mission with you. Let me tell you that in these topics, what we examine, we would like to prevent preterm birth and reduce avoidable fetal and maternal complications. And as a mission, we would like to develop a reliable screening method for pregnancy complications leading to preterm birth. We are working on 2 projects simultaneously. Our first project aims to prevent pre-eclampsia and its all complications, and in our second project we are trying to develop a reliable screening model for preterm births in Hungarian population. Before showing our results in our first topic, let me tell you a few important things about the background of pre-eclampsia. So pre-eclampsia almost affects 5% of all pregnancies worldwide. It's a well-known fact. That's why we try to prevent it with different methods, and from all of these, low-dose aspirin seems to be the most effective in high-risk pregnancies. But using this prevention, there is also not consensus about the optimal dose of low-dose aspirin. Our aim with this study is to define the optimal low-dose aspirin for high-risk pregnancies. So, for this, we involved all the studies which examined pregnant patients regardless to the risk classification. So we included low-risk and high-risk pregnancies as well, and but only those studies who used placebo or no treatment versus aspirin treatment. To have conclusions, we have to examine more than one outcome because using aspirin can cause some side effects as well. Our main outcome is preeclampsia, but we also would like to, we also wanted to assess preterm birth, intrauterine growth restriction, peripartum and postpartum bleeding as well. Our hypothesis was that 80 milligrams of aspirin is the optimal dose for preventing preeclampsia. As you can see, our flowchart selection, we included 62 eligible studies to answer these questions. Our outcomes mentioned before can be extended by the mean gestational age or the birth weight at birth, in cases of placental abruption, perinatal death, bleeding, and then neonatal intensive care unit admission of the newborn as well. From these outcomes, what we are examining, I can only show you one outcome, the first, where we examined all the pregnancies when aspirin was initiated before the 20th week. In this forest plot, you can see that most of the studies are categorizing the aspirin dose in the followings: 50, 60, 75, 80, and above. But just to present this forest plot, I first have to mention that we are working with the statisticians together, and we had to reassess some of the studies because they seems to be outliers from the forest plots. But with these outliers as well, in the end, we get a significant result that aspirin seems to be a really good prevention of preeclampsia. As you can see, the heterogeneity of the studies, and as you can see, we did a subgroup test for subgroup differences as well, and we used risk ratio for the outcome, and the outcome came significant. But we're not only carrying out a meta-analysis, we are carrying out a dose-response meta-analysis. For this reason, we would like to show you this logarithmic risk ratio of each study. As you can see, the two outliers also here that we have to re-examine these studies. But significant effect can be seen. So this figure does not show the significance, but the next figure I would like to show that this is this is what we are, why we were carrying out a dose-response meta-analysis. It is a log. In this picture, you can see a log-linear correlation between the aspirin dose administered in pregnancies initiated before the 20th week and the risk of preeclampsia. By this log-linear association between aspirin and risk of preeclampsia, every 25 milligram increase in aspirin dose was associated with a significant 7.2% decrease in the risk of preeclampsia. So in this from this point of view, the question is the following. What is the upper limit of aspirin in pregnancies? That's why we have to see all the other figures, but we are still waiting for the plots as well. As a strength for this study, this is the first dose-response assessment of different LDA doses. We have huge sample size, but also as a limitation, a classical dose-response meta-analysis requires more doses in each article, which does not fit in most of our studies. As a conclusion, we have to administer aspirin for all high-risk pregnancies, and at least we have to administer 80 milligrams daily. Our second project is screening for preterm births. As a background, in Hungarian population and in worldwide, incidence of preterm delivery is nearly 12%. Screening for preterm births is one of the most studied challenges in obstetrics, and we should develop a combined screening model of cervical sex and obstetric history for prediction. Our aim is to translate cervical length screening into a better clinical practice. So for these purposes, we We would like to examine all pregnant women with singleton pregnancies who are willing to deliver at our clinic. As an exposure, we will check the cervical length. If it is shortened, we have to compare it to the normal cervical length. Our hypothesis is that cervical length is shorter than 25 millimeter, might be most reliable predictive factor for preterm birth prediction. We would include everyone in our study and who are not unconscious or severely ill or not pregnancies complicated with fetal abnormality, and we would also have to exclude women on progesterone and cerclage inserted as well. As you can see, and we would like to measure these outcomes. Thank you for your attention. I would like to close my presentation with a quote from Steve Jobs. If you are working on something that really that you really care about, you don't have to be pushed. The vision pulls you. Thank you for your attention.
Thank you for your presentation. I wanted to ask you that how long do you administer aspirin in the pregnancy, all the way long, and if until the delivery, does it have an effect on the blood loss during delivery?
As I mentioned before, the first so by administering aspirin, our first goal is to prevent preterm birth. As a complication of preeclampsia. So after the 36th week or 37th week, administration of aspirin is no longer indicated. By the studies we examined, there were no significant differences between the amount of bleeding in the placebo and the control group compared to the aspirin group.
Thank you.
You're welcome.
Actually, this is very interesting because there are usually applied doses of aspirin. Yes. Now, actually, your data suggests that actually the more the aspirin, the better the outcome. Yes. Also, probably there are, we are sure that there are limitations on increasing the dose, but when you look at the cost-benefit, that it might be actually reasonable to do a kind of clinical study, just somewhat increased that, let's say, to 200 milligrams per day for this. So I think this should be considered in your paper too, if you agree.
Thank you. I agree.